Hello, hello. Today we have a short chat with Dr. Hallie Prescott, who is, I must say, really impressive. She is a brilliant intensive care doctor and leader. She's associate professor at the University of Ann Arbor, Michigan, and she has already contributed a lot to our field and the field of sepsis in particular. I just read this morning that she has more than 4,000 citations for her work, and we have known each other through a number of committees, including the International Sepsis Forum, where she is an active member of. And also she is associate editor of Critical Care, and I must say that she is absolutely wonderful. She does a wonderful job there. And everybody knows her with all her papers and editorials and other contributions. So Hallie, short chat. What have you read recently as important scientific papers? And in particular, we all read recently the PROGRESS study from Greece on procalcitonin-guided antibiotic therapy. What do you think of it? Is it really something new that will change our practices?
Yeah, great. Thanks, Jean-Louis. It's a pleasure to be here. Thanks for the introduction. So I did read this PROGRESS trial with interest, and I think, you're right. There have been several other trials that have looked at, essentially the same procalcitonin protocols to stop antibiotics in patients with sepsis. And so this was, a sort of an approach that has been tested before. And we even have meta-analyses that have looked at this that have suggested that it saves antibiotics. And also, the SAPS trial showed that it reduced mortality. And I think there was just a lot of questions about what is the mechanism? Like, why does that happen? And people hypothesized, maybe it gives you more diagnostic information. And so what I thought was really cool about the PROGRESS trial is that they actually gave some insights into the potential mechanism, why actually directly shortening antibiotic course could lead to improved patient outcomes. So they showed that there was a lower rate of antibiotic-associated sort of infections in the patients who had the shorter antibiotic courses. So fewer rates of multi-drug resistant infections, lower rates of C. diff. And so I think that shows the mechanism. And then I thought provocatively, they showed that when they looked at the fecal colonization rates, those were similar, but then there was this higher rate of infection in patients with longer antibiotic courses, suggesting that if we reduce antibiotics, that can prevent this transition from colonization to infection. So that's what I thought was the sort of new information or value added from this trial.
Yeah, I was a bit surprised by the tremendous difference in mortality rates. I mean, this is a small study, and they could show that mortality went down from 28% to about 15%, a decrease by 50%. Can you really believe that?
Yeah, I sort of share your, a little bit of skepticism that that's quite a large effect. And I think we have to put it into context of all the other prior trials, which have sort of, suggested that there is a mortality benefit, that it's probably much smaller than that when we sort of pool together all of these different studies that have been done previously. But the main thing, again, I thought was that sort of insight into the potential mechanism by which it's helpful. But the effect size
absolutely. I fully agree.
Large.
Because I think that as recognized by the authors, the setting is a bit special. It's in Greece, where they have an overuse of antibiotics, which is absolutely tremendous. And many of these patients went to the regular floor. 28% mortality rate on the regular floor. That's quite high, but I suppose there were also some ethical aspects because some of these patients had dementia, etc. No.
Sure.
So maybe a particular population, but it's quite interesting, isn't it? Yeah. Now, Hallie, as I indicated, you have a great interest, and you have made great contributions in the field of outcomes from sepsis. And maybe you can tell us a little bit about outcomes from COVID-19, actually, because there have been recent papers on that as well.
Yeah, absolutely. I think very early in the pandemic, almost all of the data we had was really about case rates and number of hospitalizations and then in-hospital outcomes. And there's this huge interest, of course, to know what happens to our patients after they leave the hospital. And so I've been fortunate to be involved in a couple different studies looking at outcomes after hospitalization. One was part of a statewide registry we had in Michigan here, where we had 38 hospitals participating and submitting patients to the registry. And then patients were contacted 60 days after discharge by telephone. And we had a sort of a standardized battery of questions about ongoing symptoms, and then these other longer term impacts of illness. So we asked about patients' ability to return to their normal activities and to go back to work, and then the financial and emotional impacts. And, it was, I think, a sobering findings of that study. 40% said that even 60 days after discharge, they were still not back to their normal activities. Among patients previously working, 40% were not back to work, and the ones that had returned many times had missed a full month after discharge, returned with reduced kind of activities or reduced hours. A quarter reported, moderate financial impact, and about 13% said they had used up all or almost all of their life savings as a result of their illness. And that was 20% in our ICU survivors. So, and that tended, go on.
Is it different from other types of sepsis? We speak about viral sepsis now, don't we? So is it different from other diseases?
Yeah, I mean, I think that we have seen this sort of financial impact in the United States, where not all patients have healthcare coverage, or they have like under coverage, that they're not getting sort of full coverage for things like ambulance rides or transfers. There was another paper by Katie Hausschild that did qualitative interviews with survivors from the PEDAL network trials. And, some of these stories were just so sort of devastating about people being left with these enormous bills for these, hospital transfers when they were critically ill that then get denied. So I don't think this is unique, honestly. I think a lot of what we see from COVID really is just very similar to what we've seen in other patients surviving sepsis or critical illness. But this is the first time the whole world has had their attention to these kind of outcomes. But it really sort of highlights what has been a problem for a long time in our critical illness survivors.
Do you think we have made progress in the management of severely ill patients with COVID-19?
Yeah, I mean, right now, I think we're seeing a lot of different reports from the UK and from the US and other places suggesting that in-hospital mortality is going down. And that when we look to say, is this because different patients are getting hospitalized now versus before, that doesn't seem to explain it. And so some of this seems to be that truly we're doing a better job. I think the one issue that might explain a lot of it is just this sort of surge. It's very hard to take care of patients when you have 3 times as many patients in an ICU that you're used to. And so some of these kind of differences over time, I think, are a reflection of just sort of being in these kind of contingency or sort of overwhelmed surge capacity standards. And so it'll be interesting to see whether these trends of improvement continue as people sort of hit, second peaks and third peaks in terms of their number of ICU patients.
Sure.
But certainly, I think dexamethasone, helps. And I think just recognizing that our normal supportive care, holds true for COVID patients, I think helps. That sense of being overwhelmed, of we don't know how to take care of these patients. It's a brand new disease. Like, we've kind of gotten over that and realized, wait a sec, we do know how to take care of critically ill patients. We've been doing this for decades. So,
yeah, but it's a shame we have not developed more therapeutic interventions. You mentioned dexamethasone, okay, but antiviral approaches have not been very successful. At least outside the US, people don't believe in remdesivir, and the WHO does not recommend to use it. And tocilizumab, we are still waiting for the REMAP-CAP data. Plasma administration, where we have seen the paper in the New England Journal 10 days ago. We discussed it last week at our last chat. But it was a very special population, 77 years old, who received the plasma right away with a high title. What do you think? Could have we done better, or are we missing something? Do we have some particular faith in another therapy that may come up?
Yeah, no, I mean, I think you're absolutely right. I mean, we do need more targeted therapies, and hopefully we'll come up with more of those. I've been impressed, honestly, with the recovery and the remap cap trial and the critical care community really around the world in terms of the trials that we have had. I mean, we've been debating steroids since the first time that ARDS was described. They raised the question of whether a steroid works. So we have had a lot of data come out. So I don't want to be just depressed that we have no more targeted therapies, but you're absolutely right. I mean, there's more work to be done. And it's true, mostly what we've got is supportive care and sort of refinements to our supportive care approaches.
And in sepsis in general, it will be my last question, Hallie. In sepsis in general, what is in the pipeline in your mind? It's a question which is often raised. And is it immunostimulation now? Is it something else? Is it more targeted therapy? Sometimes immunostimulation, sometimes anti-inflammatory strategies. What do you think in just a few words?
Oh, yeah, great question that obviously you could talk for hours about.
Few words.
Yeah, I mean, I think that it's interesting because how much of what we learn about COVID is then going to be applicable to sort of more patients with sepsis. For example, if this tocilizumab from the REMAC cap that, there's indicates that it is helping, will that help other patients with sepsis? I think we'll just have to see the extent to which what we've learned in COVID is applicable to more patients with sepsis. And I suspect that it probably will be.
Very good. Thank you very, very much, Hallie. I think it was excellent indeed. Have a good day, and let's treat more COVID-19 patients and other patients as well. Take care. Bye-bye.
Great. Thank you.